supposed to have a case discussion session physically in campus. Okay, although due to the recent developments, the session will no longer be a face-to-face session. Yeah, so tomorrow will not be a face-to-face session. Okay, what it will be tomorrow instead, we will proceed with a case discussion. Okay, so at 9 a.m. tomorrow, please log in to Teams, and I will start off with a half-hour introductory lecture. Okay, and after that introduction, you will then proceed to have your discussions with your respective groups. Okay, the groupings will be emailed to you today. Okay, there will be how many students are in your batch? I don't remember.
124.
124. Okay, so 124, there should be 4 in a group lah, I think. Okay, so there should be 4 in a group. So you will proceed with the case discussions, but the case discussions will be online. Okay, the case discussions will be online. You may arrange the case discussions online via whatever mechanism that is suitable for you. The easiest and the one supported by the university would be using the Teams platform. Okay, so what you can do is you can in the group, in the list of the names for the groups, I will also elect a leader. Okay, so the leader, please take charge and set up meetings if you choose to meet that way. So if you choose to meet via Teams, you can please set up your own meeting, invite your own group members, and have your discussion online. Okay, if you choose to use other platforms, it is also okay. You can use WhatsApp, of course. You can use apa namanya, Google Meet. Okay, you can also use Google Meet, or you can use any other platform that is available. However, okay, however, please make sure that the discussion is done properly. Okay, so at the end of the introduction tomorrow, I will give you the case. There will be a few cases for you to discuss, and you will proceed to do the discussion. Okay, and at around 11 o'clock, 9:30, 10:30, yeah, around 11 o'clock, once you have finished the discussion, we will start with the large class discussion, also again via Teams. Okay, is that clear enough? I don't think it will be a problem. Should you choose to meet physically instead, okay, if your group, okay, and your group only, if you choose to meet physically instead, you are allowed to. It's not an issue. Okay, of course you have to maintain all the SOPs and all the physical distancing and whatnot. Okay, but if you choose to meet face to face, you can do so as well if you feel that it is easier, or maybe if you live nearby ke apa, you want to meet at someone's room ke someone's house ke, also that is allowed. Okay, so you can choose to meet physically as well. It's not a problem, but you have to join the class beforehand, the introduction, which will be online at 9 a.m. and also the discussion for the case that will be hopefully by 11 a.m. if you manage to finish the discussion on time. Okay, so technically there will be no break. Okay, I will not afford you the luxury of a break in between. Okay, since most of you will be online, if you need a break, you can have a break anytime you want. If you need to eat, even if you need to take a bath, take a shower, you need to do your dishes or do your laundry, you can do in between the discussion. Okay, but please concentrate on the discussion as well lah. Okay, so hopefully by 11 o'clock we can start the discussion, and hopefully by 12 o'clock, maybe at most 12:30, we can finish the entire session. Okay, is that clear enough? Any questions for the session tomorrow?
No, doctor.
Okay, as for now, no questions. Okay, if you have any questions, you can just contact me via WhatsApp.
Doctor, I don't think the slides were uploaded for shock.
Is it not in the meeting chat?
No.
I'll check again. Okay, just give me a minute here. Oh, I don't have Jonathan's number. What is the address of your batch email?
Yeah, that's the one.
1909, huh?
Yeah.
Okay, should be in the email now. Did you get it?
Just received.
Yeah, doctor, received it. Thank you.
Okay. And it should also be in the file section of this channel. Should be in the file section of this channel. Okay, so let's proceed. Okay, so for this morning, we are going to quickly talk about shock. Okay, so you may have heard about shock before. Okay, when you were discussing in previous blogs, or especially when you were discussing the first case of the first PBL, the case of the first PBL, where the patient may have progress into shock. Okay, so definitely you would have had some discussion on it. Okay, so today is just going to be an overview of shock, what it is. Okay, what are the slightly different types of shock, okay, and basically how do we manage shock in a nutshell, okay. So these are the 3 TLOs, okay. You are expected to discuss the pathophysiological processes involved in the different types of shock. Number 2, describe the clinical features of the different types of shock. And number 3, discuss the therapeutic interventions for shock. Okay, so just 3 TLOs. Okay, so you need to know the pathophysiology, clinical features, and treatment. Okay. This is what shock looks like at the cellular level. Okay, so this is what shock looks like at the cellular level. So what do we have? Okay, we start off with a decrease in tissue perfusion. Okay, so when a patient is in shock, there is not enough delivery of blood and subsequently oxygen into the tissues. Okay, that will cause impaired oxygen and glucose delivery, which will lead to impaired cellular metabolism. Okay, so you have problems with oxygen and you also have problems with glucose. Okay, probably not going to talk too much about glucose today, but you definitely will have problems with impaired oxygen delivery and use. Okay, so as you can see the cascade here, there will be a number of processes that will occur. There are quite a few things that will occur. Okay, anaerobic metabolism leading to decreased ATP and an increase in lactic acid. Okay, and similarly on the other side, on the glucose side, there will be a few cascades, which will try to compensate for the impaired glucose delivery and use. Okay, so this is what happens at the cellular level. Okay, usually we are not too evil to ask you about what happens in shock at the cellular level. So, and usually we will just stick to what happens at the physiological or the pathophysiological level. So not too deep up to this level lah. Although one interesting thing here that you may want to remember, for later on during the clinicals is the effect of decreased tissue perfusion on levels of lactate, because lactate is an important biomarker for the identification of shock. So don't think whatever you have learned in biochemistry is not important. It is kind of important. So if you know the biochemistry behind the investigations that you will actually be doing later on when you practice as doctors, it will be much, much better. So lactate here is an important investigation that needs to be done when you suspect a patient is in shock. When you suspect a patient is in shock, lactate is one of the investigations that need to be done. Okay. All right, so what are the causes of shock? Okay, these are a few examples. Okay, I will give you a definitive classification for the different types of shock. So if you go through different textbooks, go through different sources and or websites and things like that, you will see slightly different classifications for shock. I suggest that you do not worry too much about it. because there is a little bit of overlap, and some people would like to think that their classification is the best. And sometimes the classification also depends on how you treat the shock and all those things. So I would say that surgeons, for example, would probably like to classify shock slightly differently than anesthetists or even from cardiologists and things like that. So the classification may be slightly different from discipline to discipline. Okay, all right. But having said that, the main outline will always be the same. It will always be the same. So you will see hypovolemic shock. Okay, which is something to do with volume. Hypo means low, volley means volume of the fluid, mic means blood. So volume, basically the blood volume, hypovolemic shock. You will see something called cardiogenic shock. Okay, and here the classification, they classify it according to vasogenic shock and neurogenic shock as well. Okay, what happens on this side? There is a decrease in blood volume. On this side, there is mainly a decrease in vascular resistance. Okay, and whatever happens, it will always lead to a decrease in pressure and a decrease in perfusion. So shock, remember, ultimately always leads to decreased perfusion. When you define shock, it always needs to have the word decrease, the words decrease perfusion. It will always lead to decreased perfusion by slightly different mechanisms. Only slightly different mechanisms. So if you can't remember all that, remember three things in shock. It will always be a problem with fluids in the body, be it blood or any other fluid, body fluid that you have. Okay, there will always be problems with the heart, mainly the action of the heart, the pumping of blood by the heart, and there will always be a problem with tone. Okay, please excuse the icon here. This one is chosen by PowerPoint lah. I don't think they understood what tone is kan. So they just choose the volume icon there for tone. But what do we mean by tone here? Tone here means the tone of your blood vessels, both arterial and venous. Okay, so it refers to both arterial and venous tone, probably a bit more towards the arterial tone, because that one is much more important in the regulation of blood pressure. Okay, so this is how I would like to classify shock. Okay, so the types of shock. First of all, you have hypovolemic, as I mentioned just now. And so hypovolemic shock can be hemorrhagic and can also be non-hemorrhagic. How can you get non-hemorrhagic shock? Anyone?
Renal failure.
Renal failure leading to, can you please elaborate?
Renal failure leading to polyuria.
Leading to what?
Polyuria.
Polyuria?
Yeah.
Polyuria. Okay.
Yes.
Would renal failure lead to polyuria? But I agree on the part of the polyuria. I definitely agree. Okay, if you excrete a lot of urine, you may experience a situation where your volume is reduced. Okay, probably not reduce the volume up to a point of shock. I don't think so. Okay, anyone else? How else would you get non-hemorrhagic shock?
Diarrhea.
Vomiting.
Vomiting. Third degree
Diarrhea
burn.
and vomiting. Okay, let's do that first. Diarrhea and vomiting. So it's not something that should be taken lightly. Okay, diarrhea and vomiting. Okay, if you have severe cases of diarrhea and vomiting, you lose a lot of body fluids. You may end up with hypovolemic shock. Okay, anybody else? How else can we get hypovolemic shock?
Burn.
Say again.
Burn.
Burns. Okay, very good. You said burns, kan? Okay, so first degree burn, second degree burn, even third degree burns. Okay, you will lose fluids. Okay, you will lose fluids. Do you remember the case of the UPNM cadet that died? Anyone familiar with the case?
Yes.
The UPNM
Yes,
cadet
yes.
that was
Bully.
what's the sort of bullied lah kan? Okay. And one of the reasons why he died was because when they applied the iron, when they applied the iron that you used to, well, the one that you are supposed to use to iron your clothes, when you use that to inflict hurt to someone, so what happens is that he suffered from burns. And what is the problem when you get burns like that? It may not look like it's very bad, or it doesn't look like it doesn't look scarred or anything like that. Okay, but what actually is happening, you would have lost fluid even with a burn that does not look too bad on the skin, because it's widespread. Even though it's not doesn't look too bad, okay, but when it happens, you tend to lose fluids. Okay, so fluids simply evaporate from your body, and that is one of the contributing factors which led to the fatality. So something for you to always remember in terms of how you can get hypovolemic shock. Okay, so hypovolemic shock can be hemorrhagic or non-hemorrhagic. Hemorrhagic is quite obvious. If you get in a car accident, you lose even 1 liter of blood, that is already enough to induce hypovolemic shock. It is that important. Why? Because we will discuss why in a minute. Okay, so that's hypovolemic shock. Second one is cardiogenic shock. Okay, obvious from the name there. Cardio means heart, genic means generated by the heart, and so this is a type of shock that is related to the heart. Okay, what is the most common cause of cardiogenic shock? Something that you have learned already last week, which is myocardial infarction. Myocardial infarction is a very common, is the most common cause of cardiogenic shock, and the most common cause of death from myocardial infarction is in fact cardiogenic shock. So when the heart fails, when the heart stops beating due to the ischemic process that occurs in the heart, which is actually not different from shock. So it's sort of like the heart itself experiences shock initially. So because when you get decreased perfusion from the coronary arteries, you get ischemia kan. So it's kind of similar to shock. That is technically shock, although not systemic. So you get sort of a localized shock to the heart, and when the heart fails, then you get a systemic shock caused by the inability of the heart to pump the blood throughout the body. So that is cardiogenic shock. If you read some textbooks, some other textbooks, websites, you may come across the term obstructive shock. Okay, obstructive shock simply means that there is something blocking the blood from being distributed. Okay, something blocking the blood from being distributed. Examples of obstructive shock would be, for example, pulmonary embolism. You will learn about pulmonary embolism in the next block. And even things like, for example, a cardiac tamponade. Have you learned about a cardiac tamponade? Anyone?
Yes.
Okay. I think maybe the anatomists have mentioned to you about cardiac tamponade kot. Or maybe someone else, Dr. Bushra ke. Okay, so when you have a cardiac tamponade, the fluid that is in the pericardial sac will tend to exert pressure on your ventricles, and the ventricles would not be able to pump properly as well. So some people would like, some doctors would like to classify this as a type of obstructive shock as well. Okay, so that's cardiogenic and obstructive. Now, the third type of shock, as how I classify it, is distributive shock. Okay, so remember when I say distributive, it's always got something to do with the blood vessels, meaning it will have something to do with the total peripheral resistance. Okay, so remember, hypovolemic means that there is something to do with the volume, which will ultimately affect the stroke volume, which will ultimately affect the mean arterial pressure, because the mean arterial pressure, if you still remember the equation, is derived from cardiac output and the cardiac output and total peripheral resistance, and the cardiac output is derived from stroke volume and heart rate. So if you lose volume, you will impair your stroke volume and you will impair your cardiac output. Similarly, if it's cardiogenic, then you will also impair your cardiac output, because your stroke volume is also impaired. Okay. Sorry, tadi hypovolemic tu is not stroke volume lah. It should be end diastolic volume lah. Okay. Okay, so hypovolemic and diastolic volume, cardiogenic stroke volume and cardiac output. But when we talk about distributive, it's always going to be about the blood vessels. When you remember distributive, you remember blood vessels and you remember total peripheral resistance. So if there is a problem with total peripheral resistance, okay, the cardiac output will not be able to compensate, and ultimately you will have a decrease in pressure, and at the end, a decrease in tissue perfusion, which is how shock manifests. Okay, so there are three types of distributive shock, three subtypes. Okay, see that. Anaphylactic shock, septic shock, and we'll also talk a little bit about neurogenic shock. Neurogenic shock may be a little bit of a mix between distributive and cardiogenic, but the main mechanism is still distributive. It's still because of its effects on the blood vessels. We're also going to discuss that a little bit. Okay. Okay, so this is what happens in hypovolemic shock. Okay, and you know all this already. Wait a minute, I have the same slides twice, only different colors. Oh, I just realized. So this slide must be Must have copied this one, I think. Okay, let's go through this slide only. All right, so there will be a decrease in intravascular volume leading to a decrease in cardiac output. Why just now? If you have a decrease in intravascular volume, you will have a decrease in end diastolic volume, which will impair the stroke volume, the amount of blood that actually gets pumped out from the heart. Okay, so you have a decrease in cardiac output. What will the look at the right side first. The body will try to compensate by increasing the release of catecholamines. Okay, so you want to try to increase systemic vascular resistance. This is TPR. Systemic. Americans like to use the word systemic vascular resistance. British, we like to use total peripheral resistance. So catecholamine release increases the total peripheral resistance and also increases the heart rate and contractility. This is the reflex response to a decrease in cardiac output caused by decreased intravascular volume. How does catecholamine increase total peripheral resistance? Anyone?
It binds to the alpha-1 adrenergic receptors in the arteries.
Okay, very good. All right, so you still remember your adrenergic pharmacology. So catecholamine release, mainly if you want to increase TPR, you have to bind to the alpha receptors in blood vessels, which will vasoconstrict. Okay, which will vasoconstrict. Okay, and also you will have catecholamines binding to directly to the heart, your beta 1 receptors. So will cause an increase in heart rate and also in contractility. Okay, so initially you will have more cardiac output, but because you are losing volume, okay, so even an increase in cardiac output will still lead to more volume loss. Okay, and this ultimately will cause a decrease in cardiac output. Okay, and a decrease in tissue perfusion and ultimately shock. Okay, all right, so this is what happens on one side. Okay, again, when you have a decrease in cardiac output, you will also have a decrease in systemic and the pressures in your lungs. Okay, and that will also cause a decrease in tissue perfusion, of course. Okay, so this is what happens in hypovolemic shock. On the other side, okay, on the other side, there will also be an attempt to compensate by, for example, your renin, angiotensin, aldosterone system. Okay, so this will also tend to increase the volume by retention of water. Okay, there may be shift of interstitial fluid when you decrease your hydrostatic pressure in relation to your interstitial pressure, your oncotic pressure. There will be a shift of interstitial fluid back into the vessels. Okay, and to some extent they may be splenic discharge. Have you heard of splenic discharge before? Anyone? Probably not.
No.
Huh? No. Is that a yes or no?
No.
I think someone said yes, someone said no. Splenic discharge in humans are actually not really proven clinically. You definitely have it in animals and in dogs, and when you do the experiment on dogs, when they lose volume, the spleen tends to discharge more red cells to compensate for the loss of volume. But in humans, I think one of the experiments they did it in deep sea divers. So that's a different population. So it's not really ni lah. If you haven't, I'm not sure if you have learned about this. If you have not learned about this, then it's a nice to know thing lah. Bukan a need to know thing. Okay. So that slide was the general mechanism of what happens in fluid loss. Quite straightforward. It's all those things that you have learned before. So this is just a reactivation of what you have learned before. Okay. Although there is another thing that can happen, okay, in hypovolemic shock, or rather one more mechanism that can lead to hypovolemic shock. And the example here is in pancreatitis. So patients of pancreatitis, they may have hypovolemic shock through a slightly different mechanism. Okay, so you can see here when you have inflammation, we have the release of inflammatory mediators and also vasoactive mediators, which will lead to a few things. You have vascular injury, you have micro DIC. Anybody who know what DIC is?
Disseminated intravascular coagulation.
Okay, disseminated intravascular coagulation. Okay, I think you have learned about it in pathology, general pathology. Yeah, you are definitely going to learn a lot more about it in detail in hematology, which is, I think, the next block after respiratory, isn't it? Okay, so you have micro DIC, you have vasoconstriction as well. Okay, and this will lead to extravasation of fluid in the third space. So in the case of pancreatitis, you have hypovolemic shock due to third space fluid loss. So you will not see an obvious sign or symptom of fluid loss. Okay, but the mechanism will be third space fluid loss in pancreatic inflammation. Okay, so this is a slightly different mechanism of how hypovolemic shock can occur. Okay, if you really read some textbooks, there may be some other textbooks that classify pancreatic inflammation as distributive shock. Okay, so the mechanisms will be slightly different, but I'm not really a fan of that kind of classification. When I was taught all this, we agreed that this was due to third space fluid loss. And especially if you go and see the surgeons, they will also agree that this one is because of third space hypovolemic fluid loss. Okay, so this is another example of how hypovolemic shock can occur. All right, so that's the first type of shock, your hypovolemic shock. This is the next type, which is your cardiogenic shock. Yeah, okay, cardiogenic shock. Okay, so remember here what happens when you have a decrease in blood pressure. Okay, the baroreceptors will send signals to the SAN, try to increase heart rate. Chemoreceptors will release, will signal for the release of noradrenaline and adrenaline, also causing vasoconstriction and attempting to increase blood pressure. Okay. Similarly, the kidneys, when they sense a drop in blood pressure, they will activate the RAS. Okay, they will activate the RAS. Okay, so you have the activation of the renin, angiotensin, aldosterone cascade. Okay, which will lead to, number one, via angiotensin, you have vasoconstriction. okay, which will increase the total peripheral resistance. And via aldosterone, you will have water retention mainly. You have water retention, and that will increase the volume and ultimately increase the blood pressure. Okay, so I've told you before what are the causes of cardiogenic shock. Okay, most common cause is myocardial infarction. Okay, there may be other causes that may be subclassified as obstructive shock as well. Okay, but the mechanism is the same. The mechanism is the same. Nothing new here. Okay, so a decrease in cardiac output, you have compensatory catecholamine release, and you have compensatory activation of the RAS. Okay, and that will attempt to increase the blood volume and or increase the total peripheral resistance. Okay, so you increase the preload stroke volume and heart rate, and to a certain point you will increase myocardial oxygen requirements because the heart will be working even more. Okay, so what happens because the heart is failing, the heart is damaged for whatever reason, cannot pump or obstructed or anything like that, so ultimately it will lead to even further cardiac output and even a further decrease in ejection fraction. Okay, have you learned about ejection fraction already? Anybody?
Yes.
Okay, all right. So you have a decrease in cardiac output that is reflected by a decrease in ejection fraction, and that will ultimately lead to a decrease in tissue perfusion. Okay, coupled with a decrease with blood pressure also lead to a reduction in tissue perfusion. With that, you have ischemia and impaired cellular metabolism. Okay, and it will occur. So this one, if it goes to the heart, it will. If it happens to the heart, it will cause myocardial dysfunction. If it happens to the other organs, it will result in organ failure. Okay, due to the impaired tissue perfusion and impaired cellular metabolism. Okay. Just quickly here on the left side, okay, here is what happens to the lungs as well. Okay, so when you have an increase in preload, stroke volume, and heart rate, okay, that increase will increase mainly the pressure in the lungs. Okay, and an increase in pressure in the lungs will cause an imbalance to the hydrostatic and oncotic pressures there, which will ultimately lead to pulmonary edema and lead to dyspnea. Okay, so this is why this is the reason why you see some degree of dyspnea in patients who have cardiogenic shock. Okay. Okay. Again, hopefully you have gone through these mechanisms when you were discussing the PBL or even in other classes last week. So this is all just reactivation of prior knowledge. Okay, let's go through the pathophysiology involved in the distributive shock. Distributive kind of shocks. So how did I classify it just now? For distributive shock, you have anaphylactic shock, you have septic shock, and you have neurogenic shock. Neurogenic shock, the main mechanism is also distributive in nature. Okay, so let's go through quickly the anaphylactic shock first. Okay, so again, you can see down here that the ultimately is the same thing. You have a decrease in cardiac output, decrease in tissue perfusion, impaired cellular metabolism, leading to shock. So down here is still the same. Up here, what is the main difference? up here, the main difference is the main mechanism. The main mechanism is still the reduction in total peripheral resistance. Okay, the main mechanism is the reduction in total peripheral resistance. And so when you have these kind of questions in the SAQ kan, this here there's a lot of things here. There are a lot of things here. So usually SAQ for this question pun 2 marks, sometimes 3 marks. If 3 marks, you need to give a little bit more detail. But you are not going to be expected to, if you can, it's good lah. But the main thing that should be mentioned is there must be vasodilation and there must be a decrease in PPR because this is the main mechanism. What causes the vasodilation? What causes the vasodilation? It is mainly the activation of these systems, complement system, and you have your histamine and also other inflammatory mediators which will lead to vasodilation. Okay, so when an allergen via IgE activates these components, it will lead to peripheral vasodilation, leading to decreased total peripheral resistance. And when you decrease total peripheral resistance, if you still remember the equation, you will have a decrease in mean arterial pressure, okay, mainly because cardiac output will not be able to compensate anyway, and ultimately you have a decrease in tissue perfusion. Okay, so this is the main mechanism. But there are accompanying mechanism as well. And you will see the mechanism better when we talk about the septic shock. This one is in septic shock. Okay, these 2 slides are on septic shock. Okay, so let's go back here first. Okay, so apart from vasodilation, there may also be an increase in capillary permeability. Okay, again mediated mainly by kinins here. Okay, there will be an increase in capillary permeability, causing the extravasation of fluids. Okay, this will cause relative hypovolemia or lead to edema, also will cause relative hypovolemia. Okay, so this is this side. Okay, and on the right side, okay, you may have constriction of extravascular smooth muscle. Okay, this leads to the main sign and symptoms, or at least the signs and symptoms that you are really worried of. Okay, so hypovolemic shock, apart from the shock due to the impaired tissue perfusion, you are also going to always be worried about the constriction of smooth muscle. Okay, all right. So that is why when you take a plane flight, it's been a long time since I took a plane because of the pandemic. Well, actually, the last time I took a plane was in it was actually in April, or because I managed to get a 12 ringgit. It was a 12 ringgit ticket to Langkawi, so it was not to be missed. So they offered it during the beginning of the pandemic, when people were scared to travel. So we took up the ticket. It was 12 ringgit one way, so it's 24 ringgit return, 24 ringgit return to Langkawi. I think just recently they also offered it again, 12 ringgit one way ticket to most destinations in Malaysia. You should take it up lah. You should take it up because the ticket, usually they will allow you to change the dates. So never ask for refund. Just change the dates. Every time there's an outbreak, change the dates. Every time there's an outbreak, change the dates. And so now I'm targeting to go to Sabah. Because Sabah is in lockdown now. So this is the right time to, I suppose this is the right time to look for cheap tickets to Sabah. Once they end the lockdown, then we can go to Sabah for a vacation. Okay, where was I just now? Forgot already. When you go on a plane, okay, when you go on a plane, well, not Asia lah, but apa, MAS, Malaysia Airlines, they usually offer peanuts to the passengers before the plane takes off. So people who have nut allergy, they have to be extra careful. Not because they're not going to eat those nuts, but the other people beside them, they may decide to open the package of nuts and things like that, and they may go into anaphylaxis. Okay, so something to be careful of if you are allergic to nuts or things like that. Okay, so be careful of shock, but also be careful of constriction of extravascular smooth muscle. Something that you do not want to have in ni. Okay, and there's also you saw just now in the other mechanism is the DIC. Okay, so in anaphylactic shock, they may also be potential for DICs or rather micro DICs. Okay, this slide does not really show how it happens. I'm going to show it in the next slide. Okay, but this is for anaphylactic shock, which you will see is not actually different from septic shock. The only difference between septic shock and anaphylactic shock is the trigger. Okay, the mechanisms actually are the same. Okay, so the only difference is the trigger. If for anaphylactic shock, the trigger is allergens. For septic shock, the trigger is your microorganism lah, be it bacteria or virus. Mainly their virulence factors, and mainly the main virulence factors thought to cause these cascades are your lipopolysaccharides. So they will affect the mainly the blood vessels. Okay, right? So the mechanisms are actually the same. If you use this mechanism for the previous slide for anaphylactic shock, you will also be correct. It's not a problem. Okay, so you have upregulation of prostaglandins. You have the increase in free radicals. Okay, this will all lead to vascular instability, leading to vasodilation. So this here is one mechanism. Free radicals, lipid mediators, vascular instability, vasodilation. Okay. On this side is the complement cascade. Okay, which will again lead to vascular instability. Okay, and on this side that I mentioned just now, the DICs, okay, is caused by upregulation of tissue factor and mainly PAI1. Anybody know what PAI1 is? Probably not.
Plasminogen activator inhibitor.
Yeah, probably not unless you Google. But we are going to learn in a little bit more detail about PAI1 in the hematology block. So we don't have to worry about it now, at least not now. Which will lead to enhanced coagulation, leading to thrombosis of the microvasculature, and you have these effects, so mainly coagulopathy, vasodilation, and also capillary leak, leading to sepsis and multi-organ dysfunction. So when you talk about the circulation, again, when it's about the circulation, the main mechanism is still what is related to vasodilation. So when you talk about shock, it's still about vasodilation, which will lead to decreased and impaired cellular metabolism. Okay. Okay. So again, this is the same mechanisms. Complement system, coagulation system. Okay. And also your kinins and your neutrophils and whatnot that will lead to where it is impaired vascular tone. Okay, all right, so these two mainly will cause impaired vascular tone. Coagulation system mainly will cause microvascular thrombus, and complement system in some way will cause impaired vascular tones and some other things as well. Okay, so there's a lot of things to mention. Okay, but again, the main thing, the main discussion point of discussion should always include the impairment to your blood vessels. What happens to the blood vessels? Because in terms of circulatory shock, in terms of shock, it's got something to do with the delivery of oxygen through the blood. And when the blood, in this case, the blood is still there, supposed to be enough, but because the pressure is lost, because the total peripheral resistance is decreased, okay, so you have your distributive shock. So that is why we call it distributive shock, in this case septic shock. Okay, this is in a little bit more detail about how sepsis leads to vasodilation. But these things you have learned already actually. Nitric oxide synthase. We're going to talk about this tomorrow actually when we discuss about the drugs used in CVS. Okay, but this one you've already learned. Okay, this one you've already learned in physiology. Okay, so just in a little bit more detail about how sepsis causes vasodilation. Okay, lastly for distributive shock, okay, you have your neurogenic shock. And what can cause neurogenic shock? Okay, can be due to a number of causes. Mainly what you see in hospitals will be traumatic actually. So if you have a traumatic injury which injures your spinal cord, may impair the transmission of signals in your sympathetic fibers. Okay, so mainly your sympathetic fibers, and as you mentioned already, sympathetic fibers through alpha receptors are supposed to be vasoconstricting your blood vessels. Okay, so this is neurogenic shock. Okay, although it's not entirely your sympathetic fibers, there are some. It depends on the level of the injury. If it's traumatic, but sometimes it may involve the heart as well. So in that case, it would be the vagus nerve mainly, which is parasympathetic. Okay. So in this case, when you have injury to the spinal cord, neurogenic, which causes neurogenic shock, it is mainly mediated by the failure of blood vessels to constrict. Okay, so there will be massive vasodilation, a decrease in vascular tone, decrease in total peripheral resistance. Okay, I don't really agree with this. It should be decrease in mean arterial pressure. Okay, which leads to decreased tissue perfusion and decreased cellular metabolism. Okay, so that is neurogenic shock, which some books classify differently. Sometimes they just put it as another type of shock, but I like to classify it as a type of distributive shock because the main mechanism will involve a decrease in total peripheral resistance. So why do we get certain signs or symptoms in shock? Okay, let's take a few, at least the few that we can explain. Okay, pale or bluish, cool, moist skin. Anybody can tell me why we get that kind of symptom in shock? Mainly in hypovolemic.
Because of the reduction of blood to the parts of body.
Okay, reduction of blood to the parts of the body. Yeah. Okay, that will cause pallor. So it will cause pale. It will cause the patient to be pale. What about bluish? What's the difference between pale or bluish?
Decreased
Bluish is
oxygen.
cyanosis, no oxygen.
Okay, it is caused by cyanosis. So again, maybe just because of blood, or maybe just because, but still maybe because of the decreased oxygen carrying capacity. Okay. What about this one? Excessive thirst, rapid and weak pulse. Okay, you know this already lah. This one is easy. Okay, so excessive thirst, rapid and weak pulse is the compensatory mechanism from fluid loss. For example, if you are hypovolemic, it will be a compensation from the due to the fluid loss. So you want to drink more water, and your heart tries to beat more rapidly, but the pulse will still be weak. Okay, pulse will still be weak. Why? Because in the case of hypovolemic shock, for example, you would be losing water. You will be losing volume. Rapid breathing. What about rapid breathing? We talked about rapid breathing just now.
Compensatory mechanism for hypoxia.
It may be compensatory mechanism for hypoxia, and or it may also be, as we discussed just now, it may also be in cases of cardiogenic shock, where blood is stuck in the lungs. Why blood stuck in the lungs? Because the heart is not pumping properly. The heart is failing to pump. So you have blood stuck in the lungs. Blood stuck in the lungs, that will lead to an increase in hydrostatic pressure, movement of fluid from the lung vessels out to the interstitium, leading to edema, and that will manifest as dyspnea and may also manifest as tachypnea, which is rapid breathing. So two mechanisms, slightly different depending on the type of shock that the patient is experiencing. Okay, here are a few others. Okay, you will get severe hypotension, of course. Why do you get cold and clammy skin? Anyone? Cold and clammy skin?
Peripheral blood vessel constriction.
The main mechanism is peripheral vasoconstriction. Main mechanism. Sometimes if you lose a lot of blood, but it's got to be a lot. It's got to be a lot. If you lose a lot of blood, you may also be cold and clammy. Okay, so cold and clammy, but mainly it's due to peripheral vasoconstriction, because the body is trying to conserve whatever blood that is left, either because of hypovolemic shock or either because of cardiogenic shock apa. So it's mainly because of the peripheral vasoconstriction. What about in anaphylactic shock? Will you still get cold and clammy skin?
No.
Oh no.
Okay, in anaphylactic shock, it may be a little bit different. Due to the circulating inflammatory mediators, you will instead get what they call warm shock. So it's not cold clammy skin, but the skin may still be warm, because the blood is still there, but the blood is not distributing correctly. So instead of the blood going to the heart, it's kind of stuck, but it's not being distributed correctly to the vital organs. So anaphylactic shock slightly different, not exactly cold and clammy skin. What about oliguria? What is oliguria? What is the definition of oliguria?
When an adult produces less than 400 ml of urine per day.
Okay, so oliguria, lack of urine. Okay, lack of urine, so quite easy to explain lah, because especially in cases of hypovolemic shock. So you don't exactly see oliguria in other types of shock, apart from hypovolemic. So oliguria is usually caused by hypovolemic shock, except if the fluids are lost via third space. Usually you still have normal urine, or maybe just a little bit decreased. So slightly different mechanisms there. Okay, so you should just Google up a bit and look at the textbooks about the different signs and symptoms of shock. Okay, there are slight differences between the different types of shock, but mostly they are the same. You will still get most of the same symptoms and signs for the different types of shock. Okay, so last part for today is we are going to talk about the treatment and management of shock. Okay, so how do we treat shock in the acute setting? You want to give the patient oxygen, because we want to try to help the delivery of oxygen in what way pun, even though they may be, the blood may be lost, so we want to increase the oxygen carrying capacity of oxygen in the blood. Okay, you may give fluid resuscitation, of course, especially when there is an obvious cause of fluid loss. So when you know already that this is hemorrhagic shock, or you know already that this is hypovolemic shock, you may want to quickly give fluid resuscitation. Even for cardiogenic shock, the consensus is we still give fluid resuscitation, even though at the end the heart may not be able to pump anyway. What kind of fluids do you give? Do you know? Have you learned about the
Normal
types of normal saline? Have you learned about the types of different types of fluid for resuscitation?
Hartmann solution.
Colloid and crystalloid.
Colloid and crystalloid. You've learned about it. Belajar kat mana? Lupa. Introductory medical physiology, is it?
I think so, yeah.
You also don't know where you learn about it. You just know. Okay. So fluid resuscitation, which one to choose, colloid or crystalloid? I'm not going to confuse you with which one to choose. Actually, when you practice later on, you will always argue with the other doctors whether to use colloid or crystalloids. So it's a choice really. Even if you look at CPG's clinical practice guidelines, certain hospitals will suggest the use of colloids as early as possible. But most of the time we will use, whatever happens, we will use crystalloids first lah. Mainly because colloids are actually a bit more expensive. Okay, so oxygen, fluid resuscitation, and of course you want to treat the patient with inotropic or vasoactive drugs. Right, so inotropic meaning you want to kickstart the heart, vasoactive meaning that you want to do something to the blood vessels. Okay, we'll look a little bit about the drugs later on. But other than that, you also want to treat other things as well that come together with the shock. So you may want to treat the anaphylaxis itself. You may want to give corticosteroids to reduce the inflammation. Okay, if it's septic shock, definitely you want to give antimicrobial treatment as well. If there is evidence of DIC, you want to treat those with anticoagulants. You've talked about anticoagulants a little bit in the PBL. We are also going to talk about anticoagulants a little bit in the case discussion tomorrow. Okay, but the main you will learn about the details of anticoagulants in hematology, which is 2 blocks from now. So for the time being, yes, you still need to know about your anticoagulants, but you don't need to know too much lah. At least know the mechanism of action. So don't worry about that. We're going to discuss that again tomorrow. And also you want to look at the glucose levels as well. Sometimes when people are in shock, the glucose levels might be low. or if the patient is diabetic, it might be high, so you want to look at that as well. Okay. So these are the drugs that can be used as inotropes and or vasoactive drugs. So both are the same. You can use both. You can use these drugs for both effects, inotropic and also vasoactive. Okay. How many of these drugs have you come across before? Anyone?
5.
5. Actually, you should have come across all these drugs before. Okay. Maybe isoproterenol I didn't really mention in the
Yeah, that's the one that we
adrenergic pharmacology. But other than that, all these drugs you should have a clear idea of how it works already. Dobutamine is a beta 1 receptor agonist mainly. Okay. Dopamine is a precursor to norepinephrine, epinephrine. Okay, but it itself also has effects on the receptors, both alpha and beta receptors. Okay, so epinephrine and norepinephrine, you know already, the ones that work on the both alpha and beta receptors. They are the main hormone and main neurotransmitter. Isoproterenol, I don't actually remember teaching you a lot about isoproterenol. Okay, but this one is also a beta 1 and beta 2 agonist. Okay, and phenylephrine, if you dig out your adrenergic lecture notes, I'm sure it's there. It's an alpha 1 agonist mainly. Mainly it's an alpha 1 agonist. Okay, so these are the drugs that you can use as vasoactive and or inotropes. Usually in the clinical setting, the still it depends on what the preference of or the guidelines for that hospital say. But it will be always revolve around these drugs. Probably not so much on phenylephrine. Phenylephrine not so much. Usually for alpha agonism, we still just use epinephrine and on epinephrine. Okay. Okay. This one you have learned before. Just shows you where dopamine is. Dopamine is the direct precursor to noradrenaline. Okay, so dopamine, when you administer dopamine, first of all, it can go directly to alpha and beta receptors, but some of it also gets converted into noradrenaline by the enzyme, and it will exert its effects as noradrenaline, the neurotransmitter. This is a slightly different drug, okay, that can be used as an inotrope. Where is the drug? The drug is here, milrinone. Maybe I should include this in the lecture tomorrow lah. Actually, it should be in the lecture notes. I haven't given you the lecture notes. And that one is for tomorrow lah. Milrinone is a phosphodiesterase inhibitor. Also can be used as an inotrope. We'll talk about it tomorrow. This is an EpiPen. Okay. Oh, it's not in English. I thought this one is English. What language is that? Oplossing voor Dutch. Maybe it's Dutch. It's either Dutch or German. EpiPen. So those of you who have risk, who are at risk of anaphylaxis, you may want to carry this around. So in case you get anaphylaxis from whatever reason, you can straight away inject yourself with this and save your life. No need to wait for other people to save your life. You can save your own life using an EpiPen. Do you use antihistamines for shock, for anaphylactic shock? Anyone?
No, yes, doctor.
Yes. Maybe yes, maybe no. Anyone here chronic user of antihistamines? Cetirizine, loratadine?
Cetirizine.
Okay, so if you are chronic sufferer of allergic rhinitis or something like that, you may need to depend on cetirizine or loratadine. These drugs are not supposed to be sold directly by pharmacists, you know. It should be signed off by a medical specialist. Okay? So I don't know what's
Yeah, but then
say that again.
but then cetirizine is sold over the counter. Cetirizine is sold over the counter everywhere.
Yeah, it's technically not. It's technically it's not over the counter lah. It's still controlled by the pharmacist. But technically, even I go and buy from the pharmacist, you know. But at least nowadays they ask you to write your name lah, so there is some sort of improvement lah. But actually, the actual law is that these drugs are supposed to be signed off by a medical specialist, not even a doctor tau. Not even a doctor. It should be a medical specialist. Okay, so that's something for you to think about. Do we use it for shock? Not really. We don't actually use it for shock. So when you become doctors, don't, oh, this patient is in anaphylactic shock, distributive shock. Let's try to give him antihistamines. Yeah, technically it should work, but it does not work quick enough. So your main choice for distributive shock, for anaphylactic shock, is just give the main neurotransmitter, which is what? Epinephrine. No epinephrine, the hormone or the neurotransmitter. That's the main drug treatment for cases of anaphylactic shock, not antihistamines. Okay, that's all for today. So remember for tomorrow, any questions for today?
Doctor.
Hmm.
On slide 8.
Slide 8. I have numbers on my slide.
The slide after the types of shock. After this one.
Slide 7 lah. So 7 ke 8?
8.
Yeah.
Okay. Why is it that at first there's increased cardiac output and then and then it leads to more volume loss, and then which would decrease the cardiac output?
Because it's a hypovolemic shock. Because the ultimate problem is decreased intravascular volume. Okay, when you have decreased intravascular volume, you have less fluid to pump out because you are losing fluids. Okay, so you have less fluids to pump out. So first of all, cardiac output will be decreased. Okay, so what happens then? The body will try to compensate. The body will try to compensate by increasing heart rate and also increasing total peripheral resistance. So they want to try to increase cardiac output. You want to try to increase total peripheral resistance. This is the equation, kan? Remember the equation? This is the main concept. If anything happens to the blood pressure because you are losing volume, blood pressure decrease, you want to compensate by increasing cardiac output, increasing total peripheral resistance. But does that solve the actual problem? So initially you will have an increase in cardiac output because the heart is pumping faster, it's more contractile, you are vasoconstricting all the blood vessels. You will be also constricting the blood vessels. So there will be an increase in cardiac output initially, but because the main problem is decreased intravascular volume, because you are losing blood, so what happens when you're losing blood and your heart is pumping faster? You will lose even more blood. Okay, you will lose even more blood. Okay, which will lead to more volume loss. Okay, maybe this one does not need to be here. So more volume loss will lead to decreased tissue perfusion and ultimately shock. Okay.
Okay, faham, doctor. Thank you.
Doctor.
Yeah.
You said increased TPR leads to increase cardiac output, but won't that decrease mean arterial pressure, not cardiac output?
Yeah, this picture is not so good lah for me lah. So this one actually increase in TPR ni should directly lead to an attempt to increase pressure. So maybe you just ignore this one lah. It's not a good.
Ignore the cardiac output part.
Ignore that. Okay. Even for this one, for exam purposes, even if you don't answer like this, I mean, if you don't answer the initial part of the body trying to compensate, you go directly from decrease volume, to decrease cardiac output, to decrease tissue perfusion, to decrease impaired cellular metabolism, that is also correct. No problem whatsoever. You don't have to mention the initial attempt of the body to compensate. So if you want to describe the pathophysiology of decrease hypovolemic shock, you can just start off with loss of volume, decrease intravascular volume, decrease cardiac output, which will lead to decreased tissue perfusion and impaired cellular metabolism. That is good enough. Okay, you don't have to mention the compensatory part here. Okay, any other questions?
Doctor, should I send the attendance?
Yeah, you should.
Doctor, for the compensatory part, is it just for the hypovolemic shock or like for all of them?
For
like
all
we
of
don't
them,
have to mention.
there will be some degree of compensation for all types of shock. Okay, so similarly, if you have distributive shock, okay, the body will definitely try to compensate mainly by what? By increasing cardiac output. So you have an increase in heart rate and contractility. Okay, definitely that will happen. Okay, any other questions? Okay, even if you have any other questions, you can always continue the discussion tomorrow. You can ask the questions tomorrow as well. Okay, so that's it for today. Thank you very much. And I'm going to send you written instructions for tomorrow via email, I think. Okay. All right. Thank you very much.
Thank you, Doctor.
Thank you, Doctor.